Hi, good afternoon, good evening, and a very warm welcome to Edinburgh Skeptics Online for the first of our 2021 Edinburgh Science Festival events. It's really good to be back after a bit of a prolonged layoff, but we hope these are the first of us getting back into the swing of things and eventually get into face-to-face events. There's a large number of online events under the Edinburgh Science Festival this year. And don't forget to check them out at www.sciencefestival.co.uk. So tonight's talk, we have Ericka Johnson, who is the Professor of Gender and Society at, and I've been told this is how you pronounce it, Linköping University in Sweden. She is a member of the Royal Swedish Academy of Sciences. She has an interdisciplinary background in sociology, gender studies, and science and technology studies. She's the author of several monographs and anthologies, including a cultural biography of the prostate, which is what our talk is about tonight. And our forthcoming book of that title is actually available to pre-order, and you should find a link in the show notes. I would highly recommend it. Go and check it out. Or you can get it at her own website, which is erickajohnson.se, Ericka with a CK in the middle. The talk tonight is all about the prostate. Many men suffer an acute case of prostate angst. We worry about our own prostates and those of others close to them, and women worry about the prostates of the men they love. The prostate's a gland located directly under the bladder. It lurks on the periphery of many men's health issues. But as an object of anxiety, it goes beyond the medical, affecting how we understand masculinity, aging, and sexuality. And in this talk, Ericka investigates what we think the prostate is and what we use the prostate to think about, examining it in historical, cultural, social, and medical contexts. So I'm now going to hand over to Ericka. So please take it away. Thank you, Dr. Johnson.
Thank you, Sean. And I'm going to share my screen here. Let's hope this works. And say thank you very much for inviting me to come and speak here today. I really wish I was in Edinburgh for real, but this is as good as I guess we can do at this point. And I'm pretty sure it's going to be ages before anybody wants to let Swedes into their country, given the way that we've responded to this pandemic. So thank you for letting me come virtually to you. The introduction was great. I guess I don't need to stick around on this slide because, and maybe I can just start off by saying, yes, I am a professor of gender and society at Linköping University. Linköping is a university that's really known for its interdisciplinary research and approaches. So while I'm at that department, I'm also part of this Center for Medical Humanities and Bioethics, which is a center that brings in researchers together across the different faculties of the university. So we have people from the medical faculty working with us, people from the philosophical faculty, and tries to engender conversations and research projects, and also teaching between and across these different fields of knowledge. The research that I'm going to be talking about today is one of these interdisciplinary research projects that we try to do as many as we can as. This one was pretty big for being in the social sciences and humanities. I was working with a team. There were 9 of us. There were people from anthropology, from sociology, from gender studies. Quite a few of us had backgrounds in science and technology studies, which is sort of a sociological approach to technology and how it interacts and co-interacts with society and social norms. We had a sexologist who was actually placed at a hospital at a urology clinic, and we had a few historians working together as well. One of the unusual things about this project, and this project being at Linköping University, was that I, as a senior lecturer at the time, was able to get this grant, bring it to my, I guess you would call it head of department, and say, I need to hire all of these people. I need to hire an anthropologist, sociologist, a sexologist, and put her money at a hospital, bring in some people with historical backgrounds, and we need to all work together in the same corridor and have the same coffee breaks and the same lunchroom conversations together. And my head of department didn't even blink an eye. Just said, okay, let's do that. And when I look, I'm not sure about how it is in the UK, but when I look at a lot of my other colleagues in the Swedish university system, I feel that most of them are located in departments that try to keep a very disciplinary approach, and it would not be as easy to hire in all of these different disciplines and different backgrounds into one department. So I've just got to go and give a big shout out to my department and the university for letting me run this project with them institutionally, because we all know all of the forms and hiring practices that you go through in a research project actually really impact what kind of research you can do. And what kind of research did we do? Right, well, that also became really difficult. So without going in too much into a philosophy of knowledge perspective here, I'm just going to put this slide up and say we did, I want to say we did interdisciplinary research. We did multidisciplinary research, and I would say that our graduate student in the project who had supervisors from different disciplines did interdisciplinary research. But what we really did was have an awful lot of conversations about what type of epistemological stances we were able to take. And this involved things like, what is data? So my historians in the project were very convinced that the data they had was the stuff that they photographed when they visited the archives, and other things that they needed to pull out as well, because they were never done finding archival material. I had the anthropologist who went out and followed students in the hospital as they were learning to do different types of intimate routine exams, which we'll talk about later. For her, the research data was her field notes and her reflections that she wrote down afterwards, the end. I had a sociologist who did a lot of discourse analysis of medical journals and medical articles. But then I also had a sociologist who was doing interview material. So his data was recordings on his phone and other, and then transcriptions of that, and then analysis of the responses to interview material. And he was working with the sexologist who was very clear in her understanding that that was the data and that was the analysis, versus how some of the others of us looked at that material and said, oh, this data is actually in conversation with larger structures in society or different norms. So for some of us, data was just a way into conversations in other fields. And then we had conversations about which contexts the data was being made in. Was the context the examination room that the anthropologist was in? Or what is context in a historical setting? Or what is context when you are interviewing somebody in their home about their experiences in the hospital? And why is this always contingent upon how it's being produced and discussed? These were questions that we had very different answers about. And it didn't help then that we had to start thinking also about what we were going to do with theory, because we had, from our different fields, very different understandings of what theory is and what theory could be or should be used for, and with the material and how and in what proportions and stuff, and what theory is good for. So I'm going to talk about the prostate, I promise, but I just wanted to preface this with a slide and a conversation about the production of knowledge, because as an interdisciplinary research group in the medical humanities and sort of working in both gender studies and sociology and history, and we had a lot of really difficult conversations. And luckily, and this is why I go back to thanking my university, we were all sitting in the same hallway for the most part. And we were all having coffee twice a day with each other in the coffee room, because that's what we do in Sweden, is that we mostly just drink coffee at very specific times. So we had to all be very civilized with each other all the time. And then we were meeting once a week in a seminar discussing what kind of findings we had and what sort of writing we wanted to do about this individually and together. So it was a lot of conversation about how we could make knowledge and what the various people in the group thought that knowledge was and was about. And we didn't always agree. So we were polite with each other, but we didn't necessarily come to consensus about this. But it was good fun. Anyway, why were we all working on the prostate anyway? Well, historically, if I want to do a genealogy of the work, it's probably because even earlier I had gotten a grant to look at what happened to Swedish masculinities when Viagra came to Sweden. And as I was going through the court cases around whether or not it should be subsidized in Sweden, and it's currently not, and the discussions about what Viagra was meant to cure, which in Sweden is basically medical conditions and nothing else, and how Viagra was being used, which of course is much outside of the medical community. What I ended up seeing was that Viagra was officially being prescribed quite frequently together with a bunch of other pharmaceuticals for men who were experiencing some sort of prostate problem. And as I was looking at that material, I began to see phrases, some in Swedish, some in English, in the medical literature, saying things like calling the prostate a constant torment, or when a patient would present with some sort of diffuse problem or complaint in the lower region, saying, well, it's probably the prostate that's haunting him. And as a person trained in medical sociology, when I saw these texts, I sort of screeched to a stop and thought, what is this doing in medical journals and medical articles? A constant torment, a prostate, a gland that haunts? What could that possibly be? So I started wondering to myself, what is the prostate? Which, coming to this from having done a PhD in science and technology studies and working a lot with sort of post-structuralist ideas about sociology and gender studies, started to make me think more, what is the prostate, when, where, and with what tools or technologies of knowing it? So I got together this team of colleagues, but I also sent off a bunch of letters to historical archives around Europe, because even though I'm not a historian, I was also kind of thinking, when did we start to know what the prostate was, and how did we start to know what it was? And one of the responses I got back to my query about what types of images or documents or models of the prostate existed was from the Medical History Archive and Library at the University of Zurich, who said, oh, we've got some wax reliefs that show the prostate. You might want to come down and see them. I was extremely pregnant at the time, so I got on the train instead of an airplane because nobody would let me on the plane. And I just took the train down to Zurich and met up with the archivist and librarian there, who took me down in the elevator down to their big mountain dig out rooms underneath, like these basement rooms in the foundational stones of the mountain, where they had all of their archival material. And they, on these shelves that you crank, those big library shelves that you crank out and make a space for it. And they opened up a couple of them and showed me these wax reliefs of the male genital region. But I've got a picture of it there on the left, that were made sometime in the late 1700s by probably, it's not signed, but probably Joseph Kurger, who belonged to a long family, multi-generational family, who had been working with wax reliefs. And this was, as far as I could tell, one of the first in their material and a bunch of the archives materials, first a wax relief of the prostate. But it was made from anatomical drawings that were in circulation at the time and were often published in books. So I was like taking pictures of this, holding it next to a pen so I could get some size information on it, photographing it with my iPhone, doing all these things that an improper historian would do when she's let loose in the archive and just thinks that it's interesting material. When the historian, when the archivist said, okay, yeah, that's really interesting, but come follow me. And she brought me over to the other side of the room, opened up some metal cupboards there, and started pulling out a bunch of boxes. And on each box was like the name of some body part, eyes, ears, legs, babies. I was like, ooh. And she started pulling them out and lifting them up. And inside each box were small little votives of that body part. So here, the other picture that you see are some of these little votives of eyes from the eye box, some in metal, some in wood, some just images, some carved, these little wax ones down at the bottom. And these were votives that were sent to the medical library by churches from all the valley, not all, but quite a few of the valleys around Switzerland, that were collected over the years, over the centuries, and are still sometimes being deposited and collected and sent to them in the small side chapels of the churches. Because people who, especially 300 years ago, didn't have access to a doctor or weren't necessarily convinced that the medical profession was the social institution that they should bring their health problems to, would pay somebody, or maybe use themselves, or often pay somebody in the community to make a model of the part of their body that was giving them problems, and bring that then to the church, where there was a particular chapel on the side of the church that they could place these at, together with lighting a candle and probably making a donation. And the archivist was like, look at these little eyes here, down there, the wax ones. They were probably made by artisans from the same family that had made the wax the prostate relief that she had just showed me. Her point here was that the skills of making wax reliefs of anatomical parts were already in circulation in particular families at the time that this prostate model was being made. My point of bringing it up here was twofold. One, because I think it shows how knowledge about the body, in this case, knowledge about how to model the body, is something that is a skill, but also something that can be transferred from one social institution to another, as are our ideas about which social institutions we should be turning to for help with our body when it's not working. The other reason I want to bring it up is that there was no votive box of prostates. Many other body parts were not there as well, but it was kind of interesting to me that the prostate wasn't there. And I started to think about why. And I think a part of it would be because, of course, the prostate, sorry, just had an invasion from the rabbits. The prostate is not so easy to know. It's not even that easy for medical doctors to know. But for a lot of men, it mostly just sits quietly and silently in the body as long as it's healthy, doing what it's supposed to do and not making a great fuss about anything. It's only when it starts to go wrong that it makes a big problem. Sorry. And it's sort of the case today as well. So oftentimes, not always, but oftentimes, when a person starts to worry about their prostate, that worry is triggered by a change in urination practices or pain in the lower region. Sometimes, quite often, the same thing together. That's one way for the person with the prostate to realize that something might be wrong. But it's also interesting to me that when I started to look at diagnostic guidelines and routines for medical doctors, many of the ways of knowing the prostate were also related to knowing urination. Or actually, if you wanted to be a little bit hard in that statement, you could say that the prostate was quite often known specifically through knowing how how a man was urinating, and is known how a man is urinating. And if you treat a prostate problem, in some cases, depending on what problem it is, knowing whether or not that treatment has worked is also measured by measuring urination changes and problems. So I've just got a few pictures here of like ways of measuring the urination in the clinic. There's that big machine where you're peeing into a particular machine to see what type of flow rate you've got, frequency volume charts, flow rate recordings, but also more phenomenological ways of knowing how you're urinating. So the picture of the urinals there at the in the public space, kind of a scary moment for a lot of men dealing with prostate issues. Or the app map here on where public toilets are, and I think this one's London, there's Covent Garden there, but many, many urban areas today are putting out maps with public toilets for tourists and for other people, because the public toilet infrastructure becomes a really, really vital part of how men with prostate issues are able to feel more or less comfortable in the public space and more or less able to participate in prior social patterns that they used like they had done before. I want to bring these up because it points to both the medical experience of urinating, medical ways of knowing about urinating as a way of knowing the prostate, but also the individual's way of knowing about the prostate. This is the big scary one. Another way of knowing the prostate is through the PSA test, or the prostate specific antigen test, which is a way of measuring how many antigens are in the blood, and it's a way of potentially knowing if there might be a cancer diagnosis lurking in the background. It's also a way of measuring how large the prostate is, especially if the person is suspected of having benign prostate hyperplasia. But to me, this becomes a really interesting way of knowing a gland that sits right below the bladder by taking blood often through the elbow or the finger, usually the elbow, and then measuring it in a laboratory. So it's a very distributed way of knowing information about the prostate through the blood as it seeps out into the body. So it's basically saying, in this case, our ways of making knowledge about the prostate are looking at the prostate not as a bounded object in the body, but more as part of a larger structure, a larger network of the ways that our body is working with the blood, with the circulation, and with the hormones that we're producing. I also have this slide here, and I'm not going to go into it too much now because of time, but I have this slide here also to remind me that the research that we did with the PSA in our project was not about whether or not the PSA is a good test, or whether or not the PSA is a screening method that we should have for the population, which is really one of the big debates about the PSA test. And during our project, there was this debate was revisited in the Swedish context because the Swedish Board of Health and Welfare decided in 2018 to again make the recommendation that the PSA test is not given as a screening moment for all men in Sweden over a certain age. It's available as a test for men who have symptoms or perhaps have hereditary reasons for suspecting they could be more susceptible to cancer, but it's not available as like a mammography is available to all women at a certain age. And this was a big debate when it came out. So the board makes their decisions based on medical and prioritizing concerns. But of course, there are other actors and voices in society who think that this should be a screening moment that is offered to men, often in the name of equitable or equal healthcare provision. So when the decision was remade in 2018, the debate flared up in the media. And what the researcher that I had working on this part of our project was kind of keen to point out in his work was that the risk-benefit analysis of PSA tests and prostate cancer over treatment and the severity of the treatment side effects for those who are potentially overtreated because they found cancer that wouldn't necessarily need to be treated are quite similar to those risks for overtreatment and the severity of side effects for cervical cancer testing. Pap smears. Yet Pap smears are a technology that in most countries have been integrated into the healthcare screening systems already. But what he also wanted to point out was that both of these types of screenings, all types of screenings basically, but especially these two, tend to produce a potential patient already at the moment of screening, or maybe you could say even already at the moment of receiving the letter home calling you to the doctor's office for a screening. So these moments of screening become moments of producing potential patients and also producing a sense of or feeling of vulnerability for those patients or those individuals. Vulnerability, which if we think about it sociologically, is actually a very distributed feeling and also tries to bring in the fact that we are vulnerable in relation to others, be that family or our community or our medical healthcare providers. And yet, when we talk about screening tests, we tend to really only focus on the biomedical aspects of it. So with the PSA test, we really only focus on whether or not it's actually good at determining the risk of cancer. We don't focus on what that moment of screening and the wait between when you leave the blood and you get your test results back a week later, and the numbers that you get and your ways of interpreting it, and the fact that you will probably then be called for another test in a year or 2 years or 3 years, and then the wait then again, and the continuous production of a series of numbers over the years for that patient. and a long trajectory of being a potential patient with numbers that they're keeping track of each year, what that does to the individual psychologically and also in terms of producing a vulnerable subjectivity or subject position. So this was something we tried to bring in there. But I also do want to bring home the idea that it's kind of interesting, not wrong, but kind of interesting that here we're knowing the prostate through the blood, through the analysis of blood in a laboratory, quite separate from the actual body. If you want to know the body with the prostate, where it is in the body, then of course you have to do that dreaded DRE, which is the butt of many jokes in Hollywood films, pun intended, and also probably one of the more feared examinations for quite a few men. And I think this is why there's so much humor around the digital rectal exam or feeling the prostate up through the anus. Here I'm going to mention the anthropologist who was in our project. She had been working previously on a project that had looked at the way that medical students in Sweden were taught how to give the bimanual pelvic exam to women or bodies with uteruses. And she had followed medical students on a particular course that taught this gynecological exam and observed the way that they were being taught. One, to feel elements of the anatomy, the cervix, the uterus, the ovaries. But more importantly, they were being taught how to interact with a potentially sensitive patient, to look the patient in the eye, introduce themselves, introduce what they were doing, ask if there were prior experiences that should be considered when doing this exam, continuously ask if everything was okay, explain what the exam was, what was happening during the exam throughout the entire process, really creating a sort of an environment of concern, sensitivity, and I guess just sensitivity, like these patients who were individuals coming into the room with emotional baggage potentially with them and during the exam. She then, in our project, followed the same age medical students in their urology courses and how they were being taught to do the digital rectal exam on prostate patients. And the difference was incredibly striking. And actually, if you read the literature, both by doctors and patients about the digital rectal exam, the experience of doing it too, there is an overwhelming feeling that the exam is something that you've got to do. You put up with it, you sort of take it like a man, get it done with and get it over with because it's important, and then you get out of there. And that was basically what was being taught to the medical students as well on how to approach the patient. There was a little bit of explanation, a little bit of saying what was going to happen, but mostly it was a darkened room. The ultrasound scan was on. For later on, the digital rectal exam was done, and then it was done. And then the patient was able to leave the room. Very, very different subjectivities were produced during these two exams. And we want to make clear that we're not saying that these subjectivities are right or wrong, that one's better than the other. But it was incredibly interesting to see how very different they were. And it's entirely possible that the patients expected to be treated in exactly those ways. And it's also entirely possible that the treatment of those patients in these ways reproduced an already existing subjectivity for those patients. An understanding of what the patients expected during the exam and also in further treatments. We want to lift that up and talk about what types of patient subjectivities are produced in our examinations, and particularly the digital rectal exam, what type of masculinity is expected, allowed, and produced during the exam. And maybe ask if we want to change that or to open up for a wider variety of different types of patients and ways of responding and reacting to them. Another part of the project looked at how we can visualize the prostate, because of course, feeling it's one thing, being able to see it's even better, but it's really hard to see. The picture over on the top left is a picture of a prostate back when the photograph was a really high-tech visualization tool. think this one was 1905. And of course, this is a prostate that has been removed. So it's cut into pieces and put onto a table and taken a picture of afterwards. It's a diseased prostate. There's also a prostate just below it being cauterized. So that will also be a diseased prostate, but that one's still in the body because it's through one of these laparoscopic surgical procedures, and it's been magnified a bit as well. The anatomy picture over on the far right shows the prostate in green. Prostates aren't green, but this is just sort of a typical anatomy drawing with the different colors that delineate the understood boundaries of the glands or the bladder or the bones, making very clear distinctions between where one part of the organ or gland is and one part where it's not, the part where it's not. And this to me is fascinating when I just, skip you 2 slides back and talk about the PSA, where we see that the prostate is known through the blood that's all circulating through the body. And then there's the ultrasound and an MRI scan of the prostate as well in sort of, what would you call those? Slides, like flat slides of the body taken in a cut through the body. These are different ways of seeing the prostate. They produce very different images of the prostate. And they also produce images that are very related to what that image is going to be used for. Is it going to be a surgical procedure? Do we know where to delineate it? Do we have to know how or why? Are we interested in how big it is? These are also just like really fundamental ways that affect our knowledge about what the prostate is. But I also want to, in the project, ask, what was the prostate? So I have this wax picture from the late 1700s that I talked about earlier. The one on the right, you'll probably recognize it, is from Leonardo da Vinci's drawings of the body. There's no prostate there. Da Vinci missed the prostate. Galen missed the prostate. It wasn't until the early 1500s that it was even mentioned that there was some sort of gland in writing. And then Vesalius, in his big anatomy book, drew a picture of the prostate, or drew an anatomical sketch of the male genitalia that had a bulge or gland that could be the prostate under it, but it wasn't named. So that was 1543. And I think he has a few sketches that are over in Glasgow, actually. There's only like 2 examples in the world from, I think, 1538, where he had actually sketched it first. But it was around 1538, 1543 when it was first drawn in Western literature, Western medical and anatomical texts. The term prostate was used first in the 1600s in plural, prostatia. Into English, it came in the mid 1700s, prostate, but there was still about a bunch of debate about whether it was plural or singular. And this is not surprising, since of course it has different lobes, and it's within a group of organs or anatomical grouping that often is very symmetrical. So you've got the testicles and the vas deferens that are both leading up to it. It would make sense that the prostate would also be symmetrical. But by the late 1800s, it was pretty much decided that in the English literature anyway, that it would be a singular gland. So the prostate became in the late 1800s a singular gland, and interestingly became associated with sexuality and sexual practices. It had pretty much, people had pretty much guessed that it had to do with sperm before that as well. They didn't really know why or what, but by the late 1800s, speculation about what kind of relationship it had to do with reproduction and sex, it was pretty rife. It was even suggested that it was less of a gland and more of a muscle. There's both muscle structures and glandular structures in it, and that its main purpose was to force out the ejaculate with enough force, enough strength, that it would hit the cervix hard enough during intercourse to cause female orgasm, and therefore enable reproduction, like fertilization. Of course, this speculation in the late 1800s was occurring at a time when it was pretty well known that you didn't need to have female orgasm to have fertilization. But this idea was still, an element of it was still there in the discourse, and that was one explanation for the prostate. It was also, because it's usually the problems with the prostate usually occur later in life. It was also thought to potentially be a result of having sown one's wild oats far too widely during youth. And this is not so strange, given that one of the main ways of knowing the prostate, like we talked about earlier, was through problems with urination. Problems with urination can be caused by the constriction of the urethra, either by like a prostate growing around it and constricting it, or by, for example, long, pretty latent, untreated gonorrhea. If you've had gonorrhea for 20, 30 years, you're probably going to have a bunch of scar tissue building up inside your urethra and causing problems urinating. And there was a lot of speculation about whether prostate problems were specifically related to gonorrhea, or if they were actually just separate. But this helped the community start thinking that the prostate was related to sex. It was also imagined that the prostate, maybe if it got to be too large and too overactive, could be the reason that older men started chasing younger skirts. And it made them behave a little bit in ways that were at the time not considered socially appropriate by the bourgeois community of medical doctors that were treating them. Though, on the other hand, there was also speculation that the prostate problems were the result of having not enough sex. So many of the patients that came and met their doctors with prostate problems, usually urination problems first, were quizzed about what types of marriage situations they had and what the marriage looked like on the inside. So there was lots and lots of discussion about this. There was also, and this is one of the things that we thought was really interesting in our project, for a brief time at the end of the 1800s, speculation that the prostate was, and this was just speculation, but we still hear this today in some discourses, was kind of homologous with the uterus. And at the time, the late 1800s, there was a fairly standard treatment for tumors growing in the uterus, non-cancerous tumors, and that was to remove the ovaries. And that seemed to help the growth of non-cancerous tumors in the uterus. So for a brief period of time, around the 1880s, 1890s, there was also speculation that it would work to castrate men, remove their testicles, to address the prostate problems and prostatitis, like the overgrowth of the prostate, actually hyperplasia. This was not exactly a popular suggestion, and most of the patients didn't really think it was a good idea. But on the other hand, at the time, there weren't really very many other options for severe problems with urination caused by prostate growth. There were catheters on the market. They weren't easy to use. They were rigid and metal, and they caused a lot of problems, and they weren't easy to keep clean. So what was in the literature called the catheter life was often doomed to be both painful and short. And a good chunk of the patients died within 2 months of starting to use a catheter to relieve their bladder, primarily from urinary tract infections that then hit them over and over again and reduced their strength and killed the patient eventually. Another option was surgery. There were surgical procedures, but up towards 40% of the patients who went under the knife for prostate surgery at the end of the 1800s, it died before they even got to come home. So it wasn't a really great option either. So for some of these patients, the hope that castration would help their prostate problems was enough to make them agree to do this. It wasn't particularly successful. They stopped it after about a decade for many different reasons, but mostly because it didn't work. But what we thought was really interesting in that example in the historical material is that there tends to be both the assumption that, and also looking at the medical, like the historical material, the idea that knowledge about the body is gleaned from the male body and then applied to the female body. So knowledge about female maladies are often taken from experiments about or knowledge about the male body. But here, in this case, we actually had an example where the female body with the uterine tumors and the removal of the ovaries was being used as the basis of knowledge from which then cures were extrapolated to the male body. And that's fairly unique in terms of medical history from what we can see. So it was kind of interesting. Anyways, these historical treatments, castration, relationship to sexuality, the way that it actually changed the ability to have sex, all of these things, historical. But today, what do we have? Well, say if you present with a prostate problem, and there are many different types of prostate problems. There's prostate cancer, which most of us think about first in first place, but also prostatitis, which is extremely interesting. And there's a chapter about that in the book that I'm not going to even talk about here because we don't have time. But even benign prostate hyperplasia, where the prostate continues to grow. It's not cancerous, but it starts to cause problems because it's much too large. Treatment options for these tend to revolve around surgery, radiation, pharmaceuticals. There's also some that use microwave treatments. There's also some that, there's lots of different ones, but these are the main ones. And their side effects, which I think are probably one of the reasons a lot of patients or potential patients are so worried about developing prostate problems, are incontinence, impotence, and loss of libido. And so we are not castrating patients today. But that's kind of a pregnant pause. We're having a lot of symptoms or side effects from the treatments that I'm not sure a lot of the patients are very happy about. And I feel the desperation to stay alive. I'm not saying, I'm not belittling the need to have these treatments, but I want to put a little caveat in here and talk about how it might be interesting to also engage in patient activism, to think about what types of lifestyles and patient subjectivities are imagined for the patient after prostate treatment, and ask if maybe the medical treatments can do better in some cases. Okay, so and I know everybody's doing the best they can. We all do the best we can all the time. So I'm gonna leave it there. But I'm just going to refresh with one quick slide about the different 5 ways of knowing the body that we talked about in here. Its effect on the body, primarily through urination, also through pain. So how the person with the prostate experiences a pathologized prostate through their daily life, in their daily practices. The PSA, a way of knowing the prostate by knowing it through the blood, through the way the prostate circulates throughout the body. The DRE, or the digital rectal exam, being able to feel the prostate, producing knowledge for the doctor of the prostate by touching it, tactile knowledge. But at the same time, producing a patient subjectivity in the relationship between the doctor, the nurse, and the patient in the clinical practice, in the examination room. Visualization tools. How do we image the prostate? What do our images produce for knowledge, and what can that knowledge be then used for in terms of treatment or diagnosis even? Where are the edges of the prostate? What do those edges say about what we think we're treating, and what side effects it's going to have? And then also comparisons with other bodies and with other diseases. What is the historical trajectory of the knowledge that's being produced in the clinical encounter? But how has that historical trajectory carried with it other ideas and other maybe norms and expectations and values than from what our patients have today? So, okay, 5 different ways of knowing the prostate. Why is this important? Well, because the book's title is called A Cultural Biography. And I wanted to use that term biography to pull up the imaginary of somebody writing often about a person and using many different sources and trying to figure out who that person is, or in my case, what the prostate is, by looking at the different ways of knowing the prostate, how it appears in different discourses, how it's used in different ways of talking about the biomedical condition of the body with the prostate, but also the cultural positioning of that person or subject with the prostate, and what kind of conversations are being engendered with that understanding of the prostate. Because finally, I think one of the most interesting results of our work was that we saw that the prostate was most present when the prostate was absent. And a lot of the prostate treatments that are available out there today involve either surgically or some other way removing or destroying the prostate. And it's at that point that most of the patients become acutely aware of their prostate. That is often no longer even there because, and this is a sort of a standard of the medical humanities, the healthy body is a silent body. It's the pathologized body that screams the loudest, but it's the loss of functioning that is attributed to the prostate that ends up really reminding the patient on a daily, sometimes hourly basis that their prostate has been pathologized. I also wanted to point out that there are some pretty big cultural assumptions underlying cures for the side effects of the prostate. I didn't have time to go into that here, but it was really helpful in our project that we had a sexologist based at a urology clinic whose job was basically to take men after prostatectomy and help them return to a sexual practice that they enjoyed. Her experiences of these interviews and counseling moments in this relatively small hospital in the middle of nowhere in Sweden, nowhere, but pretty much, really showed how incredibly varied men's experiences and expectations of their body during sexual relations are. And yet when you look at the literature about treatments for sexual side effects after prostate surgery, usually it's pretty much based on an understanding of heterosexual penetrative sex. And we wanted to sort of lift this up and be like, well, in the research that she did and that she and some of my colleagues did, there turned out to be a lot of different varieties in there. And that could be something that's worth highlighting. Because, and this is the final takeaway, men are multiple. Like the term man is far too big to actually say anything of value. Just like, and this is something that I bring to the analysis from gender studies, the whole term woman is far too broad to be useful as an analytical category or to be useful in any type of conversation about what a person may need or an individual. This has sort of been the intersectionality take home for the last, 20 years, 30 years, that things like class, race, culture, geographical location, access to healthcare, age, ability, all of these impact who we are, and what we want to do and can expect to do with our body and in relationship to others. That's the case for women. It's also the case for men. So I guess my final question for this whole talk is the prostate. What is it? When, how, where, but also whose prostate? Because all these bodies with prostates are very different bodies with very different identities. I just wanted to leave that out there. And I'm going to stop sharing and open up for questions.
The perils of technology. I was muted. You also caught me on my phone there. Apologies. I'm just writing a question. We have a number of questions have come in, and I was just writing them all down. Thank you very much, Ericka. That was really interesting. So much I didn't know. It was we've got a number of really interesting questions have come in, so hopefully you'll be able to address these as much as you can. Before I start, one of our colleagues in Edinburgh Skeptics mentioned that if anybody has issues with their prostate and the need to find public lavatories or public toilets, they can get what I believe is called a radar key from in Edinburgh, the Lothian Centre for Inclusive Living, and very similar disability charities around the UK. So they can get access to a key which will give them entry into public toilets quite easily. So I'm going to, before we proceed, I'm going to just run through a couple of questions here. One I thought was really interesting came in, although you touched on the subject just at the end of your talk there. We have a question from a person who lives in Edinburgh, in Deed Village, and I would say the name, but the YouTube handle is a little bit vowel heavy, consonant heavy, I should say. So are there any differences in subjectivities according to race, ethnicity, sexual orientation, religion, or faith? For example, do gay men or black men think different about their prostate. And I would add on to that also about transgender women. Do they look at and discuss and manage their prostate in a different way as well?
Yeah, it's a great question. It's a great question. And it's one that I don't have a simple answer for. Or my main answer for that one is we don't know enough about that. You have to give me more research money, because I really think that we need to know more about that. So if you look at the literature that is there already, the majority of it is within the biomedical paradigm, and there are differences in, for example, prostate cancer statistics between Black men and white men in the US. That's like where a lot of the research is coming from. There's also a lot of questions about whether that is the result of differences in the body or differences in access to healthcare or long-term living patterns. And that also pulls up the whole question about what is the difference between the body through a life course and the social situation, which, you know, is so entangled in so much of the way that we analyze that. So of course, same with the trans literature. There is some, very little, but there is some literature on trans women and prostate cancer. But much of that is focused, because it's in the biomedical paradigm, on how hormone treatments or hormone ingestion over a long period of time can impact prostate cancer occurrence and survival. I only found one study with interviews with one trans woman. So this is nothing. This is not enough. But there was one interview with a trans woman that I found who experienced the treatment for prostate cancer and the discussions with her doctors about prostate cancer as being focused on the inability to have sex. And this trans woman was not as concerned about that as some of the other literature would suggest that a lot of men are. But I want to embed that in an understanding that a lot of trans literature and trans research talks about the expected scripts that people who are they identify as trans are also expected to give in the medical community, like in medical encounters. So there's not enough research there. Also, different cultural expectations about what the prostate is and what it does and how prostate cancer is treated, I think would be super fascinating. And I know that the Lancet has just put together a huge commission to start studying that internationally, cross-culturally. And I'm hoping that they will involve social scientists to look at the narratives of the prostate and narratives of prostate cancer survival. So I'm hoping that, but there's really not enough research on that. So it was kind of interesting because I was doing this literature primarily in Sweden. I was also doing a few interviews in the US because I have connections to the US. And I had one of my anthropologists was down working in the Netherlands, but she was following the PSA through the blood labs. So she wasn't doing interviews with men who have had prostate treatment. So I don't know. It's a super great question. And we need to do so much more with it. Yeah.
Oh, cool.
Yeah.
Next question I've got is there a problem with hypermasculinity and individuals fearing what they assume is going to be a rectal exam if they have problems urinating or problems in, with sex and so on? And also men being very embarrassed about discussing the matter, both with their partners or with their doctors.
Well, I mean, I guess that's like, you're asking my opinion here. And my opinion is if we are afraid to seek medical care for a potential problem, then that's a problem. And whether it's hypermasculinity or something else, I don't know. But I think that there's some issues around hypermasculinity in some situations. But I don't want to in this answer, I don't want to undermine or belittle the fear of cancer and death. And I think that for so many of us, women and men and non-binary, I think for all of us of different ages, the fear of cancer and prostate cancer is so connected. And this was something that became really clear in one of the interviews. I did some interviews with the Stockholm Clinic for Sexual Health, for men's sexual health. And their primary target audience is much younger men who maybe have like, a sexually transmitted infection and need help, or an issue with like sexual practices. But I wanted to come up and talk with them about their discussion of the prostate. And of course, because the prostate can also be a source of joy and pleasure for some. So, it's like not only disease, but as we were talking about it, the nurse that I was interviewing, he was like, Ericka, you know what I need more than anything else? I need a short info film on what the prostate is, because I get so many men in their 20s coming in with, some pain down there and convinced they're dying of prostate cancer. And 20-year-old men don't get prostate cancer, but there's not enough knowledge about what the prostate is or what maybe that whole anatomy is. Even in Sweden, the Swedish, sex ed is great in some ways, but apparently not great in teaching about the prostate in schools. And so these men are terrified because they, maybe have an itch from a sexually transmitted infection that they're going to die of prostate cancer, and they don't even know where the prostate is exactly or what it does. So I think we need to help disconnect the prostate from cancer, which would disconnect it from the fear of death or the fear of potential impotence, and start talking about what our bodies are, what they do, what they can do, and how we can help keep them healthy.
Of course. You said, I think in your talk, that it was thought to be once responsible for middle-aged men having affairs. Do you think certain politicians in the UK are missing a trick there? Using that as an excuse? Never mind. I'll not ask you to comment.
Answer that one.
So, a question from Emily Raymakers. Are there imaging or scanning techniques that can replace the need for a rectal examination?
So here my medical sociologist is going to come out, and I'm going to be like, it depends on what kind of knowledge you want. So sure, probably for some of those knowledge questions, for some of the questions, definitely. And we see that happening with the bimanual pelvic exam for women, for example. It's not used at all as often as it used to be. And in many cases, you can just use an ultrasound and figure out what you want to see inside. I think the same could be true for the prostate. But I think we also have to think about which technologies are available, at what costs, and within what queuing systems and structures, and how much access does the average patient have to that. It's all a question. I mean, you guys have socialist healthcare like we do here. It's all a question of priorities and where the money's going to go and which patients are going to do it. It's pretty easy to do a digital rectal exam. Doesn't tell you everything, but it can tell you some things. So yeah.
Very quick to do. A couple of quick ones left. This is my own question, my own ignorance here. I read somewhere that the chance of men developing cancer approaches 100% as they age. By that I mean, of course, certain cancers. But is it worth treating because it develops so slowly? I mean, is that a myth that I have read somewhere or picked up, or is that true?
That's the reason the Swedish Board of Health and Welfare decided not to instigate scanning, because eventually if you scan, especially up in the upper ages, you will find and find. But after a certain age, and I'm not a medical doctor, I'm not going to tell you what that age is, but after a certain age, in a lot of cases, maybe not all, but in a lot of cases, it's not going to be the cause of death, and it will be something that you maybe die with, but not something that you die of. But at the same time, if you are a person of any age and your doctor comes to you and says, we've found cancer, that in itself is going to be enough to be really disturbing. Like that is a very difficult thing to deal with emotionally and psychologically. Yeah.
I think perhaps that, talking about it and men discussing it and understanding that, and perhaps will lessen the fear a little bit. Yeah. So it really is a final question then. How can we overcome the barriers to checking the prostate as a routine, where it's necessary? Of course, I'm not saying, as you said in the course of the talk, it isn't always necessary, and it can lead to too many, not necessarily false positives, but unnecessary treatment as well. But I'm sure there is an undercurrent or there's an undercounting of treatment by men when they get to a certain age. Oh, I'll not bother going to the doctor. I'm fine. And as you say, ignorance of men in their 20s, not wanting to go to the doctor, not understanding what it is. So is there any strategies you think you've read about which we could use to overcome those fears and barriers?
Wow, it's such a complex question. Like it's so
good one to end on.
Yes or no? Yes. but I think it's, of course, like I want to say education is everything. Learn more. But at the same time, I'm like, yeah. Or, like the healthy prostate in your body not doing anything wrong. Maybe you don't need to know so much about it. Do we really want to know about it? That's like some days I would think that. Some days I think, oh, we should all really know. I don't have a good answer. But it's like, I think it's a real fine balance between knowing about your body and what can happen to it, and also being engaged and enrolled into processes of medicalization that are maybe not necessary, or being enrolled into those processes of medicalization that are necessary and are going to save your life. Where do you come down on that? And there's obviously not an easy answer, because in the course of the interviews I did with medical professionals, urologists primarily, but also other ones, I encountered more than one urologist who whispered aside, you know what, I don't do the PSA test because I don't want to start down that slippery slope. I'm like, really? So I'm not going to tell you who. But people are out there who have the knowledge who don't want to do that either. It's so hard. But then at the same time, there are very good reasons for knowing. There's very good reasons for, testing.
Of course. I've just noticed somebody's, one of our people has posted on the YouTube link saying tack. So, well, as we discussed earlier, tack.
Yeah.
Thank you very much. Thank you again, Dr. Ericka Johnson. Thank you.
It was lovely.
We would normally have applause at this point in the live proceeding, so apologies if we can't do that, but I will do that for you. Thank you.
Thank you.
So just a brief summary. We've got a few events coming up as part of the Science Festival. On Thursday, the 1st of July, we have a cultural historian, Dr. Kate Stevenson from Edinburgh, whose recent work is focused on two disparate subjects: the history of fancy dress and the history of sex and intimacy in the Old Town Edinburgh. Not sure if those two things are necessarily related, but who knows? So her talk is called Copulation, Contraception and Controversy, Sex and the National Trust for Scotland. So when you think of the National Trust for Scotland, you think about castles and battlefields, or maybe a nice pot of tea and a scone, but sex, not so much. Well, think again. Central Edinburgh property Gladstone's Land on the Royal Mile has just launched a new tour called Intimate Lives, the history of sex and desire in Edinburgh's Old Town, looking at subjects from privacy to preferred position and from lust to lubrication. The tour draws on original historical sources from the 17th to 19th centuries, and the talk will give some context to the tour launch as well as providing a sneak preview into some of the content. It might even bust a few myths on the way. So that's on Thursday on the 1st of July. And then on Tuesday, the 6th of July next week, we've got Dr. Gail Brewer, who's a senior lecturer at the University of Liverpool. Her research focuses on individual differences in sexual behaviour. Her talk is called Dark Triad Traits, Attractiveness and Sexual Behaviour. So what she refers to as dark triad traits are Machiavellianism, psychopathy and narcissism, and the related but distinct traits characterised by a lack of empathy, exploitation and manipulation. And research suggests that these traits influence sexual and romantic relationships, for example. And her talk will outline the relationship between these traits, physical attractiveness and sexual behaviour. And then finally, on Thursday, the 6th of July, we're waiting on some details in order to announce the talk we've got for that date, but hopefully they'll be available within the next day or so. Don't forget, these talks are recorded. They will be available on YouTube afterwards, so if you've missed it, you're welcome to share it. If you've missed it, why am I talking to you now? But who knows? If you know someone that's missed it, you can let them know. That'd be a far better way of doing it. So anyway, I'm just going to wrap up there. So thank you again, Dr. Ericka Johnson, and we'll see you on Thursday. Right.